The second part of our lecture is iron deficiency anemia. Okay. Iron deficiency is the most common cause of anemia. It is the most important cause of microcytic anemia at worldwide. This is the iron distribution in the body. In this case, I usually ask you about why iron is important. Iron is important or essential component of hemoglobin and myoglobin formation, and this is not the only importance of iron. Iron is also a component of certain proteins important for respiratory and energy metabolism. Iron is a component of enzyme involved in the synthesis of collagen and some neurotransmitters. Iron is also important or essential for normal immune system. This is the body iron distribution and the transport. And in this case, I have to say that the transport and the storage of iron is largely mediated by three proteins: the transferrin receptor, and ferritin. Transferrin can contain up to 2 atoms of iron. It delivers iron to tissues that have transferrin receptor, especially the erythroblast in the bone marrow, which incorporate the iron into the hemoglobin. The transferrin is then reutilized, and at the end of their life, the red cells are broken down in the macrophage of reticuloendothelial system, and the iron is released from hemoglobin into the plasma and provides most of the iron on transferrin. Only a small proportion of plasma transferrin iron come from dietary iron absorbed through the duodenum and the jejunum. Some iron is stored in the macrophage as ferritin and hemosiderin, and the amount varying widely according to the overall body iron status. These are factors affecting the iron absorption, and I think we need to know them well. Factors which enhance the absorption include the heme iron, the ferrous iron, acids just like vitamin C and HCl, reduced serum hepcidin, ineffective erythropoiesis, and hereditary hemochromatosis. Factors which reduce the absorption of iron include the inorganic iron, the ferric form of iron, alkalis and antacid, acute and chronic inflammation, increase in the serum hepcidin, and decreased the erythropoiesis. These are general symptoms of iron deficiency, including loss of hair, neck tension, sleep disturbance, mood changes, immunity affection, severe headache, and migraine. Regarding the signs of iron deficiency anemia. Iron deficiency anemia usually have what's called glossitis and angular dermatitis. The glossitis usually painless glossitis. These patients have what's called koilonychia, and koilonychia means flat or even concave nail, which is called spooning of nail, which is characteristic of iron deficiency anemia. Patients with iron deficiency which have what's called the Plummer-Vinson syndrome or Patterson-Kelly syndrome, in which these patients have dysphagia, okay, due to presence of what's called pharyngeal whip, okay, and this is usually elicited by barium study. It's usually hypothesized that correction of iron may correct this pathological abnormality. So our patient have what's called koilonychia, angular stomatitis, glossitis, and Plummer-Vinson syndrome or Patterson-Kelly syndrome. Among other signs of iron deficiency anemia are pica, and pica are actually abnormal craving to food or abnormal dietary craving. Normal dietary craving is unknown etiology. However, it is said that it occurs due to deficiency of iron in iron-containing enzymes. I have to say that iron deficiency anemia in children is a little bit different. Most of the children have iron deficiency anemia experience irritability, poor cognitive function, and psychomotor instability. Okay. These are causes of iron deficiency anemia, which can be divided into first chronic blood loss, which is the most important cause of iron deficiency anemia. uterine blood loss, gastrointestinal blood loss, for example, duodenal ulcer, esophageal varices, maybe carcinoma of the stomach, cecum, colon, rectum, piles, or a gastric ulcer. Rare cause of blood loss are hematuria and hemoglobinuria. A second cause of iron deficiency anemia is increased demands, for example, prematurity, growth, and pregnancy. Third cause is malabsorption, and lastly, poor diet. Laboratory investigation of iron deficiency anemia includes microcytic hypochromic anemia, reticulocytopenia, in relation to the severity, reactive thrombocytosis. The platelet count usually increases, especially in case of chronic blood loss, as a reaction of hyperactive bone marrow to counteract the blood loss. I will return to the slide again. However, I have to show you the blood film of a patient with iron deficiency anemia. As you see, it's microcytic cells, decrease in the size of the cell. We have also what's called target cells, and the elongated cells are called pencil-shaped cells. So the abnormal blood film may be seen in patients with iron deficiency anemia, or target cells and pencil-shaped cells. Regarding the other iron profile, we will find decrease in the serum iron, decrease in the serum ferritin, decrease in the transferrin receptors, however, or saturation, increase in the total iron binding capacity. This is the most important finding of the iron deficiency anemia. And I have to say that other investigation of iron deficiency anemia is investigation of the cause, because chronic blood loss is an important cause of iron deficiency anemia and have to be excluded. For example, I have to order abdominal ultrasound, I have to order urine analysis, chest x-ray, sometimes I may go for CT scan. These are important items I have to fulfill, which is investigation of the cause of the iron deficiency anemia are not taken, and nutritional or poor diet as cause of iron deficiency anemia. If we need to do a bone marrow, the bone marrow in patients with iron deficiency anemia, I will find decrease in the iron stores in the macrophage. Okay. These are causes of iron deficiency anemia, which can be divided oral iron should be given for long enough both to correct the anemia and to replenish body iron stores. For example, I need to give it for about 6 months. The target rise in the hemoglobin should be 1 to 2 gram every 1 month. Causes of failure to respond to oral iron include persistence of the cause, as we just said, for example, continuous hemorrhage. Sometimes patient non-compliance, for example, failure to take tablets. Sometimes a wrong diagnosis if we didn't do investigations to confirm or to rule out the iron deficiency anemia well. Mixed deficiency, and lastly malabsorption. That's why the patient cannot get benefit from the oral iron. The second type of iron therapy is the parenteral iron. We have iron sucrose, we have iron dextran, and iron sorbitol. These are 3 types of parenteral iron usually given in patients with iron deficiency anemia. They are usually used after failure of oral iron, malabsorption, intolerance to oral essential to replete body stores rapidly. The most common side effect of parenteral iron is hypersensitivity reaction. and this is the equation we usually use to calculate the dose of iron needed by the patient. Okay, I hope this lecture is satisfying. I'm ready for any questions, and please send me on my email if you have any inquiries, and have a nice day. Thank you so much.